This chapter is going to cover some anxiety and obsessive compulsive disorders and how they're all kind of related, and the medications and some of the treatments that we're going to go through with these patients. When we look at anxiety, this is when someone has some type of uneasiness or uncertainty about something, maybe some apprehension, and there's a dread, and it may be an actual threat, but it also may be a perceived threat. When someone has fear, that is a normal reaction that people have to some type of specific danger. And then there's normal anxiety. And this is what we need every day. This is necessary for us to have survival, to have some type of little normal anxiety, which kind of keeps us on our toes and makes us more aware. Now, through the levels of anxiety, there's the mild all the way to panic can actually affect your perceptual field. It can affect the ability to problem solve, and also can have those physical effects and other types of characteristics that may happen. If you look at the table on page 281 in your textbook, they actually go through the mild toward all the way towards panic levels of anxiety and how it affects individuals. And so this is a very good table to look at and review. As I mentioned, there are different levels of anxiety. Your mild anxiety, again, that is that normal anxiety that we need, and it kind of heightens our attention and enhances our problem-solving skills. And it helps us to be more efficient and effective as workers to reach goals, kind of like when you have a test that you have to take, and so you have this mild anxiety, and it's making you like, oh, I got to make sure I review and get everything together and make sure I've read everything and I've studied and I've listened to my PowerPoints and so forth. When someone has moderate anxiety, this can cause them to grasp less of the information that's being provided for them, and it also is going to start to reduce some of their problem-solving skills to a little bit lower level. So they actually are not performing at their optimal level, and so they have more narrowed perceptual field, and they may also start to have a little bit of a voice tremor, or their voice pitch may change and maybe become shaky, maybe have some increased respirations, pulse, a little bit more tense muscles. Sometimes you'll see this in someone who has to give a speech and they have an anxiety about speaking in front of others. So you may see these types of reactions. With the severe, they have a much greater reduction in their perceptual field. They're unable to solve problems. They have that feeling of dread. You'll start to see symptoms of tachycardia, maybe some dizziness, nausea, may start to hyperventilate or have some kind of issues with sweating, withdrawal, and so they don't focus on details. Their attention is very scattered. When someone hits that panic button, as we call it, that panic level, they are completely disorganized. Their behavior, they're completely lost. They feel like everything's unreal and is happening around them, but they have no part of it. They, cannot process anything. Their speech is, you can't even tell what they're saying. They're unable to speak and communicate. May even have some hallucinations. May start to feel chest pains, dizziness, nausea, chills, may start to have palpitations and overheat, and they're actually experience like a terror. That would just be awful to go through. There's different types of anxiety and panics, and so we do have the panic disorders, and with the panic disorders, again, this is when someone has that apprehension or fear that's very extreme. They have that feeling of doom and gloom is coming. They may even feel terror to where they cannot even function. They may even misinterpret reality around them. May have the hallucinations and delusions. Some of them think they are actually losing their minds. Some people will actually feel like they are having, with a panic attack, or that they're having a full heart attack, and they will actually have many symptoms of that. And what's strange about panic attacks is they can happen just completely out of the blue. Again, so it's unpredictable about how long it will last, but usually about 10 minutes, and then it'll start to subside. When people have phobias, that can be another issue as well. And with phobias, these individuals have a constant fear of something that's really irrational, whether it's a specific object, an activity, or a situation. And it leads them to avoid something to where it can actually be detrimental to their life and their activities of daily living and getting along through life, to where they will, do everything they can to avoid it or avoid it altogether. When they do experience this, they have very high anxiety levels, and that fear that can happen. The experience can be, overpowering. It can actually cripple them at the moment in time that they're around whatever object or event that they have the phobia of. And so they may not even think about or visualize the subject or object or situation because they can feel themselves getting severely anxious about it. It's kind of like if you take me up high, or I see someone up high near a ledge, I get that complete feeling. And so I can understand, and probably many of you have different phobias. Mine is claustrophobia. I have a fear of heights, and of course, riding an airplane is a very terrifying experience for me. I don't like it at all, and I do all I can to avoid it when I can. So there are different types of phobias. Another type is social anxiety disorder, which is a type of phobia of being around others and in social situations. And so that can also be another type of disorder that you may see. So there's several different types of phobias, and they do talk about those on page 285 in your textbook. So a phobia, again, is when someone has a fear of a specific object or situation to a very unreasonable level. When we talk about obsessive compulsive disorders, these are patients have intrusive thoughts of unrealistic obsessions, and they try to control these thoughts with compulsive behaviors. So, example, someone might have repetitive cleaning of a particular object or their hands, and so they do this over and over and over and over, feeling like they still have those germs on their hands. Howie Mandel has he's a germaphobe, and so with this phobia of touching people, he said he compulsively is washing his hands or using antibacterial gels to keep his hands clean. So again, some of these obsessive compulsive disorders can actually interrupt their normal routines and days, and they have a hard time getting out of the house because they have to keep doing something over and over. And this happens on a daily basis. And again, it can cause a lot of distress if they're not able to go through those ritualistic activities that they need to do. And again, if you think back about the Big Bang Theory, and knocking on the door 3 times, Penny, Penny, when Sheldon has to do 3 times every time, and if he's interrupted, he has to start all over and do it 3 times. Penny, 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 over and over. GAD, not like EGAD, but generalized anxiety disorder is another type of disorder, and this is where people just have that anticipation of doom and gloom. They fear that something is going to happen. And it can impact someone being able to get out in the public. They anticipate some kind of disaster, and so they have poor concentration. They might even have this generalized anxiety of making poor decisions or making mistakes. Maybe someone who goes through complete fear when the teacher asks for volunteers, and they're so afraid they're going to raise their hand. This can also affect their sleep as well when they go through this, because they're just constantly thinking about this anxiety that they may have. There are a lot of defense mechanisms that individuals will have, and so there's a huge table on page 283, table 15.2, and I bet you're going to see several of these on your test. So anyway, go through those and look at some of those defense mechanisms, and again, these are ways that people protect themselves, help them to learn to cope with these anxieties. So it can actually help them even to, push things to the back of their mind. Some of them can be healthy and some may be unhealthy. So they actually show you adaptive use and maladaptive uses of these, such as someone who has denial. When their coping mechanism is this, they're unconsciously blocking something that's threatening or painful information or maybe feelings. When someone has regression, they're using behaviors that are appropriate of a more earlier age, such as a teenager maybe going back and sucking their thumb, or maybe a 4-year-old going back and starting to wet their pants or wetting the bed. Displacement can shift feelings to a more neutral person or an object. You have projection. This attributes your own unacceptable thoughts or feelings to someone else. So in other words, you're blaming or scapegoating or stigmatizing someone else. Conversion. Now this is when you have an unconscious transformation to anxiety, and it actually starts coming out as physical symptoms, stomach ache, headaches, and so forth. There's another one called introjection. This is when you have intense, unconscious transformation of an anxiety into physical symptoms as well. So it's very, a little bit more intense than the conversion. When you have splitting, this is you're not able to integrate positive and negative qualities of yourself or others into more of a cohesive image. So someone might be doing some splitting. Idealization, this is you're unconsciously attributing exaggerated positive qualities to someone else. So you're idealizing them. And then compensation is attempting to make up for any kind of perceived weakness someone may have by emphasizing a stronger point. So someone may say, well, I'm not pretty, but I'm very smart. So that would be an example of the compensation. So go ahead and look at those on that table and get an idea how some of these work. And then the examples actually help you to understand how they can be used. And looking at the clinical picture, I've just figured it'd be easier to kind of give you a statement about each type of disorder that's out there, and what you may see in the clinical setting. So go ahead and just look these over. And this is a continuation from the other slide. So go ahead and review through those, just get an idea what these are. We hear people using the word OCD, and it's been thrown out a lot over the past many years by now. When you're looking at this with disorders, obsessions and compulsive compulsions. Obsessions are, again, those thoughts. They're impulses or images that persist or reoccur, as said before, and they can't get it out of their head. It's just constant. So an obsession. Okay, so that makes sense. Then you have the compulsion, and that's that they have to ritualistically feel like they have to be doing something over and over again. They're driven, and if they don't do it, they're going to have more anxiety. So they do it so they don't get overly anxious. So what they can do sometimes is called cognitive restructuring, and it's used with these patients that have OCD. What is done is they are asked to discuss the actuality of a fear they have, and if they do not complete the task. This can help them to draw on new conclusions and test their autonomic thoughts. So if someone say, if I don't wash my hands 10 times a day before I eat a meal, I will actually catch the chicken pox. And then you ask them, will you actually check catch the chicken pox by not washing your hands 10 times before each meal. How realistic is that? And trying to let them see that this is not necessary. So another form of constructive cognitive restructuring is also positive talk, which replaces the negative. And so instead of saying, I can't, I can. So under obsessive compulsive disorders, there are some examples on table 15-7 on page 288 about different types of compulsive obsessions. There's also body dysmorphic disorder, and this is where they are preoccupied with an image of a defective body part. And it results in obsessive thinking and compulsive behavior, such as constantly camouflaging or mirror checking, and now we're actually seeing people having the plastic surgery to cover this up. So they may have false assumptions about the importance of appearance, maybe a fear of rejection of others, maybe the perfectionism may be the issue, and so they're constantly overwhelmed about something about them, or one part of their body, the way it looks. They're often concerned with their hair, their nose, their stomach, their teeth, their weight, their breast and chest size, so their buttocks, their legs. So again, this is very obsessed with the body parts, and we're seeing a lot of these people again at plastic surgeons. Another disorder that we're seeing, and you see this on TV, is the hoarding disorder. And where it becomes such a problem is when people cannot live their normal lives anymore. So they all of a sudden they feel like they, no one's coming to visit anymore, and they feel more alone. So they're trying to take up for this absence by putting more things in their home, and it makes them feel more comfortable. So again, you can see this accumulation of belongings. And sometimes they may or may not even be aware of the problem. So that can also be an issue as well. It's likely that men are affected at much of the same rate as women. And that many times they don't seek help. It's someone else who seeks the help for them. Hair pulling, skin picking disorders, again, it's very irresistible to the individual. They do a lot of times try to hide the issue. However, you'll start to notice bald spots with the skin picking. You can actually start to see the sores. They may use nail cutters, tweezers, fingernails. So again, it's important they focus on their face, their head, cuticles, their back, their arms, legs, hands, feet. So we worry about the sores and pain and scars and infections, but it's actually a relief for them, and it's how they deal with stress. So that is another type of disorder that you may see. Other compulsive disorders can actually even be the cutting. That can be also a very big issue that we worry about. So again, looking at the skin, and other disorders can be drugs, gambling, sex, spending, and so forth. So it's not just these, but there's many other issues as well. When we think about the nursing process, we want to do our assessment. So again, we want to assess these individuals. Also, do they need harm unless to themselves, or if they're suicidal or their compulsion can lead to injury. Of course, we definitely want to have them admitted. Other than that, they're usually treated in an outpatient center. Again, we need them to recognize that this is their illness and get information about what they've done in the past, what has helped, and trying to get an idea of what all it is that they are doing and how we can help them. Many times nurses can get very frustrated themselves, and that that the person is out of control, and why can't they just stop? So behavioral change is often accomplished very slowly, so we have to remember that. And for us who don't have that problem, it's so easy for us to say, well, just stop. It's like telling the young girls that you see with cutting scars, just stop cutting. And they'll say, you don't understand. It's a form of relief when they cut. And it's something that they have control, they feel they have control of by doing the cutting, but actually they don't have control of it. You also want to, assess their psychosocial events in their life, ask them what's going on right now. And maybe they will identify a problem that's actually causing the issue at the time. When it comes to your outcomes, identifying your outcomes, again, you're going to link those with your diagnoses. And then in planning may involve selecting interventions that can be implemented in a community session, or they might encourage more planning activity sessions in like groups. Some of the diagnoses that you might see could be ineffective coping, chronic low self-esteem, anxiety. Those who are actually hurting themselves, would be your self-mutilation, where they're either skin picking, pulling the hair, cutting, and so forth. When you think about applying the nursing process and looking at implementation, you want to think about the anxiety levels when you're dealing with anxiety. So, we want to help them to be able to concentrate and decrease anxiety. And so we want to ask them open-ended questions and explore and seek clarification to make sure we have a better understanding of what's going on with them. And then also, too, you want to make sure that we keep the conversation and communication lines open, making sure that we only bring up relevant information, and that we don't want to increase their anxieties, or they're going to not want to come in because the nurse is maybe the nurse doesn't feel comfortable discussing something, changes the topic, and this makes the patient feel even more stressed. So we want to make sure that we give a nice calm presence for our patients, recognize that they are in distress over their anxiety, and that we are willing to listen to their issues. When it gets to the severe or the panic levels, again, they have a poor grasp of what's going on with them, and they can't, control or solve problems, and sometimes they're just out of control of their actions. So we want to make sure they have a safe area, that they feel safe, and that we are definitely meeting all their basic physical needs, and so they don't go into a form of exhaustion. We want to do any kind of anxiety relief measures to reduce their anxiety. We want to minimize stimulation, make sure they have a quiet room. We want to provide them with a lot of physical gross motor activities, maybe to help to release some tension, and then they may also have to have medications. Communication, again, with the patient may be scattered or disjointed while they're in that severe panic level, so sometimes it can be very overwhelming trying to help them to reduce that level of anxiety. They do have some suggestions on table 1512, talking about some of the basic interventions that can be used. And so if you look at some of those, you can see some of these interventions and the rationales out from beside there. So I'm not going to read through those for you, but they are there. And then they do give some basic guidelines, nursing interventions for these patients. On page 294, it's listed 1, 2, and 3. And then when we have counseling, again, we want to help them with their coping and communication skills, always intervene when they are in a time of crisis. And then with the team needs to work together, especially if it starts to interfere with their health. Sometimes hospitalization is actually necessary, And so we want to make sure that we are effective and that we keep the stress levels down, maintain a good, safe environment, low stimulation, and then, working together and with this patient, hopefully we can get them to de-escalate. Promotion of self-care activities, again, we want to think about what is essential and what activities do they need to be fulfilled with. Well, we're going to think about nutrition, fluids, making sure they're going to the bathroom, making sure they're getting plenty of sleep, and making sure that they get up each day and, getting dressed and grooming. We want to think about their skin integrity, especially if they have a compulsion with overwashing their body and they start to break down the skin and it could become infected. Or, maybe they can't make a decision. Do I get a shower? Do I get a bath? Do I get a shower? Do I get a bath? And so trying to help them through those situations. Be very matter of fact and in a supportive way. And we do still want them to encourage their thoughts and feelings during this time. We don't want to brush it off and say, you have to do this, you have to do that. But we want to limit their stress levels, so we do want to give them an option, but we also want to help guide them to make their choices so they don't become overly anxious just trying to make a choice. When it comes to implementation and about medications, we want to think about our medications. So again, you want to look over some of your medications. They have a nice chart set up on 15.3 on page 297. And so you want to look at some of your medications that are available for patients. You have antidepressants and you have your Ativan, and then you also have some of your benzodiazepines. Benzodiazepines are like Ativan. Make sure, though, that when you teach a patient who is on a benzodiazepine, such as Ativan, that we tell them to reduce their caffeine levels, no more than a cup a day, because you're going to reverse what you're trying to do. But they should not operate heavy machinery because it can make them a little more of a sedative type of environment. We want to avoid alcohol and other sedatives because that can accentuate the sedative effect. So we want to be very careful with our patients who are taking those medications for anti-anxiety. Another one that we want to think about is lorazepam, as well as with the lorazepam. It's good to treat anxiety, but it's better to be giving that one PRN because it is a short-acting medication, whereas if you have something like, let's say, Buspar, it's good for a long-acting type of medication. So since it's long-acting, you definitely would not give this as a PRN medication. Looking back at your antidepressants, these are your SSRIs, and again, they are always the first line of medications that we like to give for types of anxieties and OCDs. This is your Paxil, your Lexapro, Zoloft, Prozac, Paxil, and I think I said Zoloft already. Again, and Paxil and Zoloft are the kind of meds that SSRIs that have a very calming effects. Sometimes they may have to give an SNRI, such as Effexor, and it can be successful when treating people with who have several anxiety disorders, such as Cymbalta as well. Is more for your generalized anxieties. If they give an MAOI, that's usually for someone who is needs to be treated because they're resistant to the other medications and treatments. Your anti-anxiety drugs, these can be used to treat your somatic and psychological symptoms that come along with some of these disorders. And as I said, benzodiazepines are usually most commonly used because they have a quick onset of action. but but you have to be careful because they do have a potential for a dependency, and should only be used for short periods of time, even though they're long acting. I said not to be used as PRN, but they shouldn't be taken for a long period of time, such as like months or years. They have a really good table or box 15.2 on page 297 that talks about anti-anxiety medications and some of the patient teachings that you would want to use. So that's very helpful, and I would definitely look that over. Oh, also with BuSpar, we have to be careful or make sure we teach our patients that with some of the drugs, it may take 2 to 4 weeks before they actually see the full effects. So they, for them to not just stop taking because they aren't getting better. So again, encourage your patients to keep taking the medication because it can take a while to take effect, and they should never just stop taking a medication either. They need to be weaned down. This last slide also talks about some of the other interventions for advanced practice, which is your cognitive therapy. And again, we want to try to get them away from the negative thoughts and beliefs about themselves and others. And again, we can use that cognitive restructuring that I had talked about earlier. In behavioral therapy, we can teach and use physical activities to decrease some of their behaviors that are very anxious, or they're avoiding something. So we can use the relaxation, the modeling, systematic desensitization, flooding, and then thought stopping and response prevention. With the flooding, it's what it does is they expose patients to a very big amount of stimuli that's not very desirable, and so and they're hoping to get rid of the anxiety response. So the patient can learn through many exposures to something that they can survive something, and so hopefully the anxiety will start to diminish. So that's what flooding is. It's kind of a weird word to hear. The last one is cognitive behavioral, and this is where they're going to combine the two to help reduce anxiety responses. So they're going to do some cognitive restructuring, psychoeducation, some breathing and muscle relaxation techniques. So they kind of, what they do is they just put 2 and 2 together, and hopefully they will, heal this patient or help make their life more adaptable for them to use and get through day-to-day life. Okay, that's all I have, and we'll get ready to do Chapter 16 next.